Let's start with Meckel's diverticulum. This is the most common GI tract abnormality, happens in about 2% of the population. And how it works is that you have something called persistence of the vitelline duct. The vitelline duct, which I'll show you a picture of in a second, connects our embryologic midgut to the yolk sac. So what does that look like? If this is our embryologic GI tract, it can be broken down into our foregut, our midgut, and our hindgut. And notice this region here. This is our vitelline duct, and its only purpose really is to obtain nutrients from our yolk sac. And our yolk sac is something that we can get nutrients for when we're very, very, very young in utero. It helps us until our placenta develops fully and can provide all of the nutrients that we require. So once the placenta is big enough and it's starting to carry the load, we don't really need our yolk sac or our vitelline duct anymore, and they actually involute. So these will naturally go away, and that's totally normal. So if we look at normal involution, what that would look like is everything's gone, no problems. In Meckel's diverticulum, we're going to have some persistence of the vitelline duct. So instead of involuting all the way, we might have some persistence right here. Some other things that they rarely test on, you can get something called a vitelline fistula, which is where barely anything involutes and it actually connects with your anterior abdominal wall. And because it's directly connected to your GI tract, you can actually have meconium or poop coming out of your like belly button through this. So if you ever see that, consider a vitelline fistula. And the last thing they sometimes test are on vitelline cysts. This is where instead of involuting, you can get a cyst form. It could be anywhere along the vitelline duct. So sometimes it'll be pressing against the abdomen and you can palpate a vitelline cyst if you palpate around the belly button. Something to keep in mind is that the vitelline duct contains stem cells that can differentiate into other cell types, like gastric mucosa, pancreatic tissue. And we'll get back into why that's important when I talk about how Meckel's diverticulum usually presents. And the type of diverticulum that you have to know is that this is a true diverticulum involving all 4 layers of our GI tract. So in our GI tract, we have a lumen, a mucosa, a submucosa, our muscular layer, and then the serosa or adventitia. And when we look at diverticula, you can have a true diverticulum, which involves all 4 layers, or a false diverticulum, where the muscular layer is not involved. So a true diverticulum would look like this, where all 4 layers are involved in the outpouching, whereas a false diverticulum would look like this, where you can see the muscular layer here has been cut and broken through. So the diverticulum actually only contains 3 of your 4 GI tract layers. And you can see some of the conditions that involve a false diverticulum. And in this case, this is our first example of a true diverticulum where all 4 layers are involved. So how does this present? Most of the time, you don't know about it. It's asymptomatic, but you could also have painless GI bleeding. That's a very common complaint. Why do you have painless GI bleeding? Well, if we consider that there's some persistence of our vitelline duct, recall that this duct contains stem cells that can transform into other tissues, one of which being gastric mucosa. So if you have some part of your stomach cells produced in this area, you can produce a lot of hydrogen ions. And there's nothing to really neutralize these hydrogen ions because all of our bases were up in our duodenum. So these hydrogen ions can damage your GI tract and lead to painless GI bleeding. You can also get right lower quadrant abdominal pain for that same reason. It could be painful bleeding as well. And you also might experience the symptoms related to specific complications of Meckel's diverticulum. And some of those complications are obstruction, volvulus, and intussusception. I'm just going to talk about why intussusception might happen in somebody with Meckel's. Intussusception is where if our bowel is flowing from left to right on the screen, it's where this region actually telescopes into this region. And normally this wouldn't happen under normal conditions, but in Meckel's, you actually have a lead point where the small bowel can get, the proximal section can get stuck on that distal section and end up pulling through. And the only reason that was possible is because if I go back, this right here will act as the lead point where, let's say, this distal section actually gets stuck, and then this section can kind of come through, causing this to happen. So how do you diagnose this? You diagnose this through something called the technetium 99M pertectinate scintigraphy. Yeah, you don't have to know that name. You don't have to know how to say it, but you definitely have to know that name. If you ever see a pertectinate scan, they're probably talking about Meckel's. It's called a Meckel scan in real life, but they're not going to give you that on a test because they're not nice. And I just want you to know what this pertectinate scan does so it's easier for you to remember. All its whole job is to detect gastric mucosa. So I really liked this picture here because it shows you exactly what Meckel scan does. You can see up in the top right, it's detecting gastric mucosa in your stomach, which is totally expected. You'll also see some gastric mucosa. You'll see some of the contrast get into your bladder, which again is totally normal. This right here that they've highlighted in red shows that there's gastric mucosa in your right lower quadrant, which should not be there. And that's because you have a persistence of your vitelline duct or Meckel's diverticulum that's ending up producing some gastric mucosa in that region. A mnemonic that you'll commonly see is the rule of twos. You'll see that 2% of the population is affected. It's 2 times likelier in males. You'll often see it diagnosed within the first 2 years of life. The diverticulum itself, that persistent vitelline duct, is about 2 inches long and usually located around 2 feet from your ileocecal valve. And it can remind you, the rule of twos can remind you that there's 2 types of ectopic tissue, your gastric mucosa and your pancreas. The next embryologic condition I want to discuss is intussusception. This is caused by telescoping of the proximal bowel into a distal segment. And we just saw that in the Meckel's thing, but it's where this section goes into this one and leads into this. Oftentimes, we don't know the cause of intussusception, but there are several conditions that act as lead points. The first being Meckel's diverticulum that we discussed earlier. You can also have a mass that can cause intussusception, and if you ever see intussusception in an adult, you should assume there's some sort of mass there, whether it's cancer or polyp or what have you. It's unclear, but masses can cause that. Another lead point I want you to know about is called lymphoid hyperplasia, and this can be caused by either the rotavirus infection, vaccine, adenovirus, IgA vasculitis. On tests, they usually like to test this in the context of rotavirus, whether it's the infection or the vaccine. So let's talk a little bit about the lead points. We talked about Meckel's earlier, where if you have this vitelline duct persistence, that can act as a lead point and cause intussusception. Imagine if you have a mass here that basically gives you a point that can, a lead point where the bowel can start to focus in and move toward it. And then lymphoid hyperplasia, I'm going to remind you from our anatomy section that there are Peyer's patches, especially in the terminal ileum. And what can happen is that in the setting of an infection or a recent vaccination, these can get very big and they can ultimately act as a lead point and also cause intussusception. So how does this present? You're going to usually have an infant with severe colicky abdominal pain. You're going to have current jelly red stools. This is a picture of current jelly, and I want you to realize that it kind of looks like blood and mucus, and that's exactly what it's composed of. So if you can imagine that when you're in this process of intussusception, what's going to happen is that the enterocytes that are on in this section are going to get damaged and they're going to slough off. And when they slough off, you're going to have blood and mucus released, and you'll have that current jelly stool. You see this current jelly stool in acute mesenteric ischemia as well. And that's because you have a significant region of bowel necrosis. So you have a lot of enterocytes sloughing off in that condition as well, resulting in this blood and mucus filled current jelly stool. Oftentimes on tests, they'll mention that a child will draw their legs into their chest. They'll kind of curl up into a ball to alleviate the pain. And you can remember this by the mnemonic that people will curl in with intussusception. You can diagnose it in a few ways. The first being you'll notice a sausage-shaped mass you can palpate on physical examination. On ultrasound, you'll see a target sign, and you can see it on the right especially. You can see that view showing that one bowel is stuck inside of the other. And the last way to diagnose it is through an enema. And the good thing about an enema is that it's diagnostic and therapeutic. So oftentimes we treat people with presumed intussusception with an enema, and you can use a wide variety of things. And why that works is because an enema will cause back pressure, and that can undo this intussusception that's been going on. Unfortunately, enemas don't always work. So if the patient still has persistent recurrence of this intussusception, they may need surgery to fix it. Now we'll move on to gastroschisis and omphalocele. So I cannot say that word, gastroschisis. That is a para-umbilical bowel herniation. And what para-umbilical means is just it's around the belly button. It's not 100% symmetric down the midline. It's kind of a little off center. This is not covered by peritoneum, so you'll just see open bowel that's popping out. This has no association with a genetic syndrome either. So let me show you what that looks like first. This is our embryologic gut. We have our foregut, midgut, and hindgut. Here's our anterior abdominal wall. What happens in gastroschisis, I can't with that word, is that you have a defect in your anterior abdominal wall, and it prevents it from closing 100%. So instead of it being closed like this, you might have a little opening here, and some of that bowel as it grows can escape through that region. And again, this is para-umbilical. You can notice how it's not directly along midline. And just remember with gastroschisis that it's not covered by peritoneum and it's not associated with genetic syndromes. You can see a picture of that right here. And a good mnemonic that I saw, I believe in first aid, I want to give credit to where it is. I'll check. I think it's first aid, is that they remember gastroschisis and omphalocele for the first letter. So G is an asymmetric letter, and that can remind you that it's para-umbilical or asymmetric herniation. And you can notice that G cannot encase anything, and that should remind you that the bowel that comes out in gastroschisis is not covered by peritoneum. Let's move on to a word that I can pronounce a little bit better, omphalocele. So in omphalocele, this is a midline bowel herniation. This is surrounded by peritoneum, and it is associated with a few genetic syndromes. So how this works is that in general, our body, as our abdomen grows and our liver grows, what's going to happen is our liver pushes our midgut and causes what's called a physiologic herniation. And normally this happens and we have a little bowel rotation. And then as our abdominal cavity gets bigger, our bowel will come back into our abdominal cavity. So you don't have a herniation anymore. In omphalocele, you have a problem of actually coming back into the abdominal cavity. So you have a midline bowel herniation that stays in place even after birth. And this is surrounded by peritoneum and it's associated with genetic syndromes. And this is a picture of what that might look like. And the mnemonic that first aid gives is you have to think about the O in omphalocele. And just remember that the letter O is symmetric. So you'll have a symmetric herniation right down the midline. And remember that the letter O, you can put something and encase it in the letter O, and that should remind you that omphalocele is surrounded by peritoneum. And here's a chart if you're just studying quickly and you want to know. You have a paraumbilical herniation and gastroschisis and a midline and omphalocele. You get no peritoneum in the condition that starts with the G, and you do have peritoneum in omphalocele. And just note that G is not associated with genetic syndromes, whereas omphalocele is.
Thanks for watching. I hope you enjoyed the video. Please like, comment, and subscribe for more content.